¿Cómo le puse que está?
Alt F5.
Es que no sonaba un poco, sonaba pequeño. A ver, repítelo otra vez. ¿Una presentación?
No se escucha. Si quieres, dale ahí, por favor. Sí. En donde está el Teams, métete Teams. Ajá. No, en la pantalla.
Ahí está.
Ajá. Aquí, en esa, por favor. En configuraciones. No, no, acá. Ahí, por favor. El otro. Configuración de dispositivo. Ajá. Y acá en altavoz ponle. Dale aquí un clic, por favor. Ponle Monarch. Ahí está.
No, espérame.
¿Mande?
A ver, ¿cómo está? Ahí está. Good morning, my name is Gabriela Salinas. I am first year president of the Hospital Universitario in Monterrey, Nuevo León, and I will present an interesting case. Patient data is a 36 years old woman with no relevant medical history. Last menstrual date 8 days ago. The patient refers inability to conceive for 4 years. She has a negative pregnancy test. The last pregnancy was 10 years ago. Verbally refers to normal laboratory hormonal results, denies pelvic pain, painful period, increased menstrual flow, pain during sexual intercourse. She goes for an evaluation with a doctor who suggests a pelvic ultrasound for a structural evaluation. This is the ultrasound for the patient and in the way abdominal. In the ultrasound, we see a normal size uterus with no apparent abnormality. The normal endometrial line size for age. At the time of the evaluation with the ultrasound, we found a rounded hypoechoic image was identified in the right annex. We observed a random image with well-defined borders, heterogeneous echogenicity, with a predominant hypoechoic associated multiple reticular echogenic image without flow to the evaluation with Doppler color, which will be better characterized with a transvaginal ultrasound. In the differential diagnosis, we have endometrioma, which consists in a functional endometrium outside of the uterus. A frequent place to find it is in the ovary in 75% of the cases, and is bilateral in 50%. The ultrasound is the first imaging tool, and classic appearance is diagnostic. Most common symptoms are infertility, cyclical or chronic pain, palpable mass, and incidental loading mass on the ultrasound. In the ultrasound, we will observe a diffuse low-level internal echo in 95% of the case. Homogeneous echo texture, like this, unilocular complexes, increased stroke transmission, like this, and most often with or arising from ovary and often characterized as ground group. Cis wall with variable appearance, diffuse thickening of common and wall nodularity in 20% of the case. In this ultrasound, we are seeing bilateral 6 adenal mass with homogeneous low-level internal echoes, and in the color Doppler endovaginal ultrasound, we demonstrate scattered minimal area as flow in the middle thickened wall on this endometrioma, which is typical. We can exclude this diagnosis because the patient didn't report any symptoms and due to the echogenicity of the image. And another differential diagnosis is an ectopic pregnancy. It's an ectopic gestational sac developing in fallopian tube. The best diagnostic clue is no intrauterine pregnancy with tubal mass with echogenic cul-de-sac fluid or blood. No specific annexal mass is common finding. The location is in annexa, but separate from the ovary. We need a positive pregnancy test, and if we use a real-time observing during the transducer pressure, we will see ovary will slide separate from annexal mass. Making a ring of fire, sign of increased flow in trophoblastic tissue. The most common symptom is first trimester pain or bleeding. All other symptoms are palpable adrenal mass or cardiovascular shock. In this ultrasound, we see an echogenic tubal ring adjacent to the uterus. We have free fluid adjacent in the top gestational sac. And in this ultrasound, we see heterogeneous left annexal mass separated from the ovary. And we can exclude this diagnosis by negative pregnancy test. Another differential diagnosis is a tubovarian abscess. Is associated with the pelvic inflammatory disease. It's a spectrum of disease including endometritis, salpingitis, tubovarian abscess, and ophoritis. Usually sexually transmitted disease involving organisms such as Chlamydia trachomatis or Neisseria gonorrhoeae can occur for extension of inflammation for adjacent organs such as appendicitis, diverticulitis, and colitis. The symptoms are usually present with pain, fever, and vaginal discharge. Can result in tubal scarring like infertility, ectopic pregnancy, and chronic pelvic pain. Inflammation of ovaries enlarges edematous ovary and a complex pelvic fluid colic. In the Doppler ultrasound finding, we can see an increased color Doppler flow of walls and fold of tube or ovary. In this ultrasound, we can see a longitudinal ultrasound of the left to ovarian complex. There is a complex fluid in the abscess, which is distinct from the ovary. In this coronal transvaginal ultrasound of the right ovary and thickened tender fallopian tube secondary to acute salpingitis. And we can exclude this diagnosis because the patient doesn't have antecedent of infection and doesn't have any symptoms. This is the ultrasound of the patient. We can see a right annex with measure of 5.5, 4.5, and 4.5 with an approximate volume of 52 cc. Increase in size for the age of the patient at the expense of rounded image with well-defined borders, heterogeneous echogenicity with a predominant hypoechoic associated multiple reticular mobile echogenic imaging to the compression maneuver, which project posterior acoustic reinforcement with a flow to the evaluation with color Doppler. Yes, and we can say this is data compatibility with hemorrhagic cyst. And is managed as hemorrhagic cyst in the right annex and is suggested to make ultrasound control in 6 weeks. 6 weeks. And I'm going to talk about the hemorrhagic ovarian cyst. It's a hemorrhage into the cystic space in ovarian parenchyma. The pathology is secondary to a hormone response, and the stromal cells surrounding a maturing Graafian follicle become more vascular, and after the oocyte has been expelled, the Graafian follicle develops into a corpus luteum with a highly vascular and fragile granulosal layer, which will rupture easily, forming an hemorrhagic ovarian cyst. The clinical presentation, the patient may present with sudden onset pelvic pain, pelvic mass, or they might be asymptomatic, and the hemorrhagic ovarian cyst is an incidental finding, like the patient. An hemorrhagic or a ruptured ovarian cyst is the most common cause of acute pelvic pain in a febrile Premenopausal woman presenting to the emergency department. The majority resolved spontaneously, several pain resolved with hours in more than 19% of the case, and mass will be disappear in more than 90% in the case with 8 weeks. The largest is more likely to cause acute pain presentation when acute abdomen. If large might predispose to a nasal torsion. If we have a rupture, we will need a supportive treatment adequate. In the ultrasound, in this endovaginal gray skull shows typical areas of reticular or less internal echoes are due to fibrin stents with the hemorrhagic, and using the color Doppler can help to confirm the vein etiology of the ovarian hemorrhagic. Yeah, in this color Doppler, the internal reticular echoes seen in the cyst are not vascular. The treatment depends on this. The reproductive age less than 5 centimeters is no follow needed. More than 5 centimeters is 6 to 12 week follow up. Is early postmenopausal is follow up ultrasound to ensure the resolution, and late postmenopausal is considered surgical evaluation. Surgical treatment for severe symptoms of like ovarian torsion or rupture with significant intraperitoneal hemorrhage. If it is recurrent, consider ovulation suppression. Thank you.
Good morning. My name is Adriana Michel Ruiz Delgado. I am a first-year radiologist resident at Hospital Universitario in Monterrey, Nuevo León, Mexico, and I will present you my interesting case. We don't have enough information about the patient's history. We only know that she is a one-day-old female and currently without respiratory distress or oxygen requirements. This study was taken on the day of the baby's birth. This is a thoracoabdominal X-ray in the cubitus, showing partial substitution with a rounded opacity at the right hemithorax by air. It has a multicystic aspect and does not make a mass effect in the mediastinum. We can also see that the correct position of the umbilical venous catheter at the most cephalic end of the inferior vena cava. Now we will see some differential diagnosis based on the radiographic findings we have just seen. The general Imagen differential considerations include the bronchogenic cyst. They can occur in the mediastinum or be intrapulmonary. The most common location is in the middle mediastinum. The cysts usually appear as soft tissue density rounded structures, as we can see here, sometimes with compression of surrounding structures. Another differential diagnosis, the congenital diaphragmatic herniation, variable appearance based on hernia contents and whether herniated bowel contains air. We can see in the X-ray the bowel loops within an hemithorax, in this case, the left hemithorax. Another one, the congenital lobar overinflation or congenital lobar emphysema, is a congenital lung abnormality that results in progressive overinflation of one or more lobes of a neonate's lung. hyperlucent and hyperinflate lung segment. In this case, we have the right middle lobe, and we have the atelectasis of the right and inferior lobes. And also, we can see a mediastinal shift. Another finding, the nasogastric tube is in the distal esophagus, and it needs to be further. Okay, the final diagnosis of our patient, congenital pulmonary airway malformation, are multicystic masses of segmental lung tissue with abnormal bronchial proliferation. CPAMs are considered part of the spectrum of bronchopulmonary fagot malformations. The term congenital pulmonary airway malformations has been recommended as being preferable to the term congenital cystic adenomatoid malformations, since the lesions are cystic in only 3 of the 5 types of the lesions and adenomatoid in only 1 type. This is the patient study. This is an angiotomography of the thorax with axial cuts using low radiation dose protocol, performing coronal and sagittal reformatting. Okay, we can observe in the right lung, in its posterior and lateral segment of the lower lobe, a lesion of irregular shape and lobulated edges, multiloculated with non-confluent cystic components, the largest with a diameter of 1.2 centimeters, which has communicated with the lateral bronchi. The congenital pulmonary airway malformation, we have that represents approximately 25% of all congenital lung lesions. The estimated incidence is approximately 1 of 1,500 to 4,000 live births, and there is female predominance. The diagnosis is made antenatal. It's less frequent diagnosis in older children and adults. The clinical presentation, the most common signs or symptoms are an acute progressive neonatal respiratory distress or an incidental diagnosis on prenatal ultrasound. Another signs or symptoms as failure to treat recurrent infection, fetal hydrops, pulmonary hypoplasia, and stillbirth from large lesions. The diagnosis is usually either made on antenatal ultrasound or in the neonatal period on the investigation of progressive respiratory distress. If the lesion is large, they may cause pulmonary hypoplasia with resultant poor prognosis. In cases where the abnormality is small, the diagnosis may not be made for many years or even until adulthood. When it does become apparent, it is usually as a result of recurrent chest infection. The pathology, the condition results from failure of normal bronchoalveolar development with a hamartomatous proliferation of terminal respiratory units in a gland-like pattern without proper alveolar formation. Histologically, they are characterized by adenomatoid proliferation of bronchioli-like structures in macro or microcysts lined by columnar or cuboidal epithelium and absence of cartilage and bronchial glands. These lesions have intracystic communications and unlike bronchogenic cysts, can also have a connection to the tracheobronchial tree. We have 5 subtypes, mainly according to the cyst size. The type 1 is the most common. 70% of the cases are large cysts, 1 or more dominant cysts, 2 to 10 centimeters in size, and may be surrounded by smaller cysts. The type 2, 15 to 20% of the cases, cysts are less than 2 centimeters in diameter and may be associated with another abnormalities as a renal agenesis or degenesis, pulmonary sequestration, or congenital cardiac anomalies. The type 3, the 10% of the cases, microcyst, less than 5 millimeters in diameter, typically involves an entire lobe, has a poorer prognosis. The type 4 is an online cyst, typically affects a single lobe indistinguishable from type 1 on Imagen. And the type 0, this is very rare, practically incompatible with life. We have the ultrasonographic findings. The fetal ultrasound, we can see a cystic mass in the fetal thorax, as we can see here. We have also a mediastinal shift. We can see the heart. Another finding important, the diaphragm is intact. The radiographic findings, chest radiograph in type 1 and 2 may demonstrate a multicystic air-filled lesion. The large lesions may cause a mass effect with resultant mediastinal shift, depression, or even inversion of the diaphragm. In early neonatal period, the cyst may be completely or partially fluid-filled, in which case the lesion may appear solid or with air fluid levels. The CT has a number of roles in the management of CPAMs. First, it more accurately delineates the location and extent of the lesion. Secondly, and most important in surgical candidates, CT angiography is able to identify systematic arterial supply if present. We can see an axial contrast enhancement CT shows a predominantly air-filled multilocular cystic lesion in the left lung. A dominant cyst is surrounded by smaller cysts, and there are air fluid levels. And finally, the treatment and prognosis. The type 1 lesions have the best prognosis. The type 0 lesions are incompatible with life. And the surgery is the treatment of choice in symptomatic patients, both in those presenting early with respiratory compromise and in those presenting later with recurrent infections. And that's all. Thank you.
Good morning, my name is Estefania Brosi Garcia, and today I will be talking about an interesting case from our institution, Hospital Universitario Dr. José Eleuterio González. A 56-year-old male was admitted to the emergency department due to shortness of breath. He noticed changes in the color and consistency of the left breast. He also refers chronic use of perlutol, a contraceptive injection. On this enhanced thoracoabdominal CT, through the thorax, we see a lesion of irregular morphology and enhancement in the left breast, with measures 48 millimeters by 25 millimeters and thickening of the left skin. Left mesic pleural effusion with inversion of the diaphragm associated with pleural thickening was also seen. Right pleural effusion and pericardial effusion were also seen. Blasted lesions compatible with metastatic disease located in the appendicular and axial skeleton. Right unilateral mammography was performed. Due to the clinical conditions of the patient, it was not possible to perform a mammogram of the left breast. The right breast has heterogeneously dense tissue. Right retroaurial regions without alterations, observing thickening of the skin up to 4.9 millimeters. No visible lymph nodes were seen in the right axillary region. On Trossvins grayscale ultrasound image of the left breast were an irregular hypoechoic mass with indistinct margins, with a long axis parallel to the skin without flow in its evaluation with color Doppler. It measures 26 by 22 by 15 millimeters. This lesion requires histopathological correlation. In the right axillary region, a lymph node with diffuse thickening of its cortical of 8.3 millimeters is observed, with which conditions a compression of the fatty ileum. Two lymph nodes with a mesh appearance are observed in the left axilla, one measuring 21 by 18 by 19 millimeters and the other 26 by 23 by 18 millimeters, which require histopathological correlation. In the lateral cervical level 2, enlarged, round, hypoechoic lymph nodes were observed with the loss of the fatty ileum. A fine needle aspiration biopsy of the lesion in the left breast and two lymph nodes was taken the same day of the mammography and the ultrasound, and the final diagnosis was an invasive ductal carcinoma. There are multiple differential diagnoses such as papillary carcinoma, dermoid cyst, lipoma, angiomyolipoma, schwannoma, intraductal papilloma, gynecomastia, fat necrosis, and extramammary metastasis to breast. Invasive ductal carcinoma, also known as infiltrating ductal carcinoma, is cancer that began growing in a male duct and invaded the fibrous or fatty tissue of the breast outside of the duct. Male breast cancer represents less than 1% of all male cancers and less than 1% of all breast cancers. Several risk factors have been identified, such as genetic and hormonal abnormalities. Its clinical issues are a firm, painless, subarachnoid mass, usually eccentric to nipple. Other symptoms are nipple discharge, nipple retraction or inversion, and skin thickening. First, a mammography should be taken in two basic views: medial lateral oblique and craniocaudal of both breasts, and if needed, we can take additional positions. Presence of an eccentric mass with well-circumscribed, lobulated, or spiculate margins on mammography raise suspicion for malignancy. Microcalcifications are uncommon on male breast cancer. By ultrasound, we can identify an irregular, lobulated, convex hypoechoic mass with indexing or angular margins, with posterior shadowing or enhancement. It is necessary to look out for axillary node metastases. How to look for them? With the absence of fatty ileum or asymmetrical cortical thickening. A biopsy is made for breast cancer diagnosis, and the management and treatment for male breast cancer is similar to that for breast cancer in women, consisting of surgery and adjuvant radiotherapy with or without additions or hormonal therapy or adjuvant chemotherapy. The prognosis is similar compared to women. And these are my references. Thank you for your attention.
Okay, good morning. My name is Cristian Acosta David. I'm first year resident of Radiology and Image in the University Hospital, Dr. Jose Eleuterio Gonzalez, and this is my interesting case. Okay, this patient, a 46 years old male, arrives with a history of hypertension and alcoholism. Began his condition in 5 months ago, presenting abdominal pain with transrectal bleeding in 2 episodes after injection of alcohol and spicy food. Currently under the care of the gastroenterology service, who requests this study to rule out possible chronic liver disease. Currently, the patient is asymptomatic. Imaging studies, an ultrasound of upper abdomen was performed. In this grayscale ultrasound, we can see the morphology of the liver was preserved. It was a normal site. In the right side, we can see this color Doppler ultrasound without flow redistribution or thrombosis of the portal vein. In this grayscale ultrasound, we can see with a smooth edge without data of chronic liver disease. On examination of the gallbladder was identified in this anterior wall around the image with well-defined edge, congenital with dinner projects, shadow or posterior acoustic reinforcement. On the right side, we can see the image present itself out without flow on Doppler examination. We can see in the grayscale ultrasound an image measure of 4 by 4 millimeters, not mobile to the change in the patient posture, for which was concluded has a vesicular polyp. The diagnosis is gallbladder polyps. The gallbladder polyps are elevated lesions of the mucosal surface of the gallbladder. The vast majority of the lesions are benign, but on some occasions they can be seen as malignant lesions. The differentiation of benign and malignant polyps is very important because the benign lesions are very common and the malignant lesions require early intervention. to improve the result, and this is the reason why this case is interesting, because our conclusion impacts on the follow-up and treating the patient. In this case, we can see an actual T2-weighted image with FATSAT MR of patients show 2 gallbladder polyps. Although tiny polyps are rarely malignant, ultrasound surveillance is typically advocated, as we are going to see you later in this list. The epidemiology, the vesicular polyps are relatively common and are mainly identified in patients between 40 and 50 years of age, and are more common in female patients with a ratio of 2.9 to 1. They are seen in up to 9% of the population, and the 90% of the lesion will be cholesterol polyps. It has been observed in patients who have a history of family adenomatous polyps and post-Jaeger syndrome. The clinical presentation, the polyps are incidentally found at upper abdominal imaging, usually during imaging for abdominal discomfort. Most common signs are asymptomatic. However, in some patients, the polyps may present clinically with obstructive symptoms, mainly abdominal pain when eating fatty foods, as in case of cholecystolithiasis, and can cause signs of obstruction in some cases pancreatitis. In this debatable association with chronic disease. The ultrasound findings to the best tool we have is endoscopic ultrasound. However, it is not available in most centers and requires special training to handle it. By transabdominal ultrasound, they are observed as echogenic nodular lesions of the mucosa of the gallbladder, which will be not present show a shadow of posterior acoustic enhancement. In image A, this is a grayscale ultrasound of a 47 years old woman, shows a 1 centimeter pathologically confirmed adenomatous polyps. The likelihood of neoplasia increases with the polyp size, but most gallbladder polyps are hyperplastic. In the image B, we have an ultrasound of 43 years old man, show 2 tiny gallbladder polyps. The evaluation of mobility during the exam in real time helps to differentiation between polyps and small stones or slush that do not form a shadow. The nodal lesions that present the common tail artifact are suggestive of cholesterol polyps. Large polyps may present internal flow on color Doppler examination. No characteristic findings had been found that differentiate between benign and benign lesion and malignant lesion entities. Multiple and small lesions are usually benign. Compared to large and single lesions, they are usually malignant in nature. An image located to our left, we can see a grayscale ultrasound in 42 years old man presenting for routine screening for hepatitis B and demonstrates a small gallbladder polyps in both the anterior and the posterior wall of the gallbladder, consisting with cholesterol polyps. The image B, we have ultrasound of a 43 years old woman with right upper quadrant pain, shows mild gallbladder wall thickened and multiple shadow small slightly echogenic polyps that measure less than 5 millimeters. And in this case, when can see what they were talking about early in this case, that the polyps may present themselves with pain if they cause an obstruction the gallbladder. The identification of polyp by CT is difficult due to the lack of image resolution, since of underestimated the size of the lesion compared to the ultrasound. They are better visualized by contrasted tomography showing rounded lesions are added to the gallbladder with variable enhancement. By this imaging method, the malignancy of the lesion can be predicted. Tomography is used for studying regional and distant malignant entities, evaluation lymph nodes, invasion into the liver, and metastasis. In imaging studies, they can be detected by CT or MRI, but are better characterized by ultrasound. Here we have in the left a non-contrast axial CT scan, and the right we have a contrast CT scan, which we can see polyp lesion enhanced with well-defined edge and no possibility differentiated to benign or malignant lesions. The risk factor for malignancy is age over 60 years, cholecystolithiasis coexisting of sclerosing cholangitis, irregular thickening of the gallbladder wall, and sessile morphology of polypoid lesions. The size of the lesions is the most important predictive factor of malignancy. Since lesions smaller than 6 millimeters are very unlikely to be malignant. The 100% of polyps larger than 20 millimeters are malignant. The 43 to 77 of polyps between 10 and 29 millimeters are malignant, and the 94% of polyps smaller than 10 millimeters are benign. The follow-up is very important because it's the reason this case. Follow-up studies are not suggested in patients with lesions smaller than 5 millimeters. In polyps between 6 and 9 millimeters, ultrasound follow-up is recommended in 6 or 12 months. In patients with lesions greater than 10 millimeters, cholecystectomy is recommended. And this patient with lesion greater than 18 millimeters to carry out extension studies with a cholecystectomy posterior. Thank you.
está un poco enorme. Es que no tiene. No se puede. No sé qué tiene algún prohibición. O no sé cómo lo. Bueno, pues. Good morning, my name is Diana Ortega. I'm coursing the first year of radiology residence at Hospital Universitario in Monterrey, Nuevo León. Today we are going to review a clinical case. First of all, let's start with the patient background. It's about a 36-year-old female with no relevant personal or family history who shows mild vaginal bleeding for the past 6 months, which was presented after sexual intercourse with no other accompanying symptoms. The patient took the decision to visit a private gynecologist who performs a physical examination with no relevant findings, so he performs the pap test showing a pathological result. The patient is referred to our institution and we made an ultrasound. We start the study with an abdominal approaching in which we can see 3 ultrasound images in grayscale of the uterus, and if we focus on the images, we can realize that it's a non-normal cervix. Observing this first image in a sagittal view, we can see a prominent cervix enlarged. Even in the parasagittal views, is evident mainly in the left side, which corresponds to this image. Describing this grayscale image in sagittal view of the uterus, we can say that the cervix is a round mass with irregular and lobulated edge, hypoechoic, compared to the rest of the tissues, and it has a heterogeneous ecotexture. We continue with transvaginal approaching, where we corroborate the findings with the transabdominal pelvic ultrasound, observing 2 grayscale ultrasound images in transverse and longitudinal plans with in irregular, heterogeneous, hypoechoic mass extended into the cervix. The approximate measures were 3.5 by 3.5 by 3.1 centimeters. In the moment when we explored the mass with Doppler color, an increase in internal flow was evident. So we conclude the final report as suggestive finding of neoplastic process. Some days after, I went to the pathology department to collect the results of the biopsy performed to the patient, which was positive for squamous cell carcinoma of the cervix. 2 weeks later, a CT scan was performed in our department to determine the extent of disease, where the findings were an irregular mass in the cervix with no evidence of metastatic disease. So to conclude the clinical case, the final diagnosis was squamous cell carcinoma of the cervix, and according with the radiological findings and the FIGO classification of the 2018 for cervical cancer, the patient is in 1B2 stage due to tumor measures, which are more than 2 centimeters, but less than 4 centimeters, and no evidence of metastatic disease. Talking about cervical cancer, is the 4th most common cancer in women of all ages. Its high incidence is due to a large number of women who don't screen to avoid the disease. This is an important point to mention because cervical cancer can be prevented by using vaccination. It affects all groups of ages, but mainly women in fertile age. Nearly all cases of cervical cancer were resolved for human papillomavirus infection, especially subtypes like 16 and 18. Like I said, cervical cancer is an important public health issue in our country, and In this graphic is represented white, being the third most common mortality caused by all types of cancer and having the second place by gynecologic cancer. The clinical presentation is variable and depends on the grade of invasion. In initial stages, most patients are asymptomatic. Nevertheless, symptoms like vaginal bleeding, mostly postcoital, and painful sex. And when the disease starts to spread, it can be present other symptoms such as abdominal pain, urinary symptoms, fatigue, and weight loss. All of these caused by tumoral invasion. The physical examination is made by using a vaginal speculum that can reveal from a normal cervix with any signs to ulceration or an exophytic mass. The final diagnosis, as well as we'll know, is made with biopsy, and the most common histological subtypes are squamous cell carcinoma and adenocarcinoma. Talking about the radiological features, the most common imaging method to evaluate cervical cancer includes ultrasound, CT scan, and MRI. Sorry for that. Ultrasound is not the best imaging method, but sometimes it can be used as initial approaching, like in this patient. When we use ultrasound to examine the patient, we need to perform transabdominal as well as transvaginal examination to correlate both findings and get a better image of all the structures. We can find a normal test or a mass which could be irregular, heterogeneous, hypoechoic, with internal flow increase on Doppler color. Moreover, some of the structures that we can evaluate are the size of the tumor, the parametric invasion, the tumor invasion to other structures like vagina or uterus, and we can see if there is some grain of hydronephrosis, what helps us to assess the extent of the disease. CT in general is not very useful in the assessment of the primary tumor, which usually is in hypoenhancing or is enhancing to normal cervical stroma, and also the CT helps to evaluate the same structures that I have mentioned with the ultrasound. But additionally, CT helps us to see adenopathy or metastatic and recurrent disease. Talking about MRI, I'm not going to go forward because we already got one entire class of this theme, but it's important to know that this method is the best to assess primary tumor, invasion, metastatic disease, and it helps to determine the prognosis and the stage. But in general, the T2 sequence is the most used for evaluating the tumor and local staging. The typical imaging in T2 is a hyperintense mass disrupting normal hypotense cervical stroma. And thanks for your attention.